Okay, so we will get started. It's about 2 after 5:30, so we'll just kind of kick it off. I'd like to welcome everyone and thank you for coming tonight. I am Beth Eddings. I'm the Assistant Director of the Medical Alumni Association, and I will be kind of acting as moderator through this call. Um, so, just a couple quick reminders. Keep yourselves on mute just so that we can make sure everybody can hear. And then, if you have any questions that you come up with during the discussion, just submit them through the chat feature and we will kind of work through those as time allows. So, now I would like to take a brief moment to welcome our guests. Doctors Mike and Harry Saag, and thank them for joining us. This is how it will work. The first 20 to 30 minutes, they'll kind of share their story, and then we will go from there and kind of process through a Q&A. So without further ado, I will let y'all take it away.
Great. Thank you so much, Beth. Hi, Harry. Harry's in Nashville. I'm in Birmingham. Probably the best way to start this is just to tell the story. A little bit like Hamilton, who lives, who dies, who tells the story. So, Harry, why don't you start off since you're the one who caused all the mess?
Yes, this was mostly my doing. So we'll have to rewind the clock back to March of 2020, which I think we've all aged about 10 years here in the last almost 18 months. But if you can remember what it was like pre COVID-19, I was in New York City at the time. New York City, I'll say in February, was still rocking along full speed. In retrospect, when we went back and kind of looked at, as a hospitalist at NYU Langone Health, just to make sure that was emphasized, when we looked back at February, in retrospect, we did notice, we actually had more folks coming in with pneumonia, NOS, of some kind of respiratory illness. In hindsight, but as many of you know, a lot of times folks have some kind of respiratory illness, whether it's viral or whatnot, and the diagnostics. So the flu the flu antigen's negative, and the flu PCR is negative, and the sputum doesn't grow anything, and we just kind of treat for, again, pneumonia and NOS. But obviously in February, there's no question that in New York City, the virus was no question circulating at that point. And obviously for any of you all who've visited Manhattan, it is basically a cruise ship on land. So it is probably if you are COVID-19 virus, it probably looks at New York City and, how you still folks riding the subway and the packed trains. We were as good of a host city for New York, for COVID-19 as could be humanly possible. And so, because, we all were late to the party in New York City, I'd say, we were all living our lives in February, myself included, around, I'd say, early March is when, I think some signals started going off. We obviously were at that point, we're all familiar with, this idea. You might remember that there were some slides that were leaked from the American Hospital Association briefing to the CDC, where some of the projections around future hospitalizations in the summer started saying, hey, this might be a bigger deal than anyone is thinking about. And then obviously in late February, early March was also the time of that Biogen conference in Boston, the quote super spreader event that I think also, in kind of culmination with these other events, started setting off the flare guns of, Houston, we may have a problem. And so it was kind of early March, and around that time, my dad, as you'll hear, was actually in Boston at a conference, not the Biogen conference, but a different conference. But go ahead.
So let me take it, because I was in Boston at the exact time that Biogen meeting was going on. So this is the end of the first week of March, and I was part of a leadership of a large meeting, about 4,000 infectious disease, HIV docs who are going to come together for the big meeting we have every year in Boston. And it was going to be held at the Heinz Center. And there was debate for 2 weeks, a lot of intense debate on email about, well, people can vote with their feet. They know they can take their own risk. But by the Friday before that weekend, when I was in flight to Boston, they said, nope, we're going virtual. So in 48 hours, this meeting went from a live meeting to a virtual meeting. And by the time I got there, I was just going to attend and kind of be in the background, but because everyone else had canceled, I sort of rolled up my sleeves and helped run that meeting. So though it's different between the meeting I was at and Biogen was night and day. Biogen went ahead and kept having their meeting, and we stopped, and there was nobody who was in our meeting in person, which was only about 25 people, who became infected from the meeting, whereas Biogen, there were at least 160 plus who then spread it further once they left. So that's one big difference. To fast forward a little bit, Harry, as you heard, was in New York, and he was going to be driving back to Birmingham. And I figured, well, he don't want to drive by himself. I'll get a train to New York and we'll drive together. I figured it might be safer than flying. And so hopped on the train on that Thursday morning, got to Penn Station and came up, and because it's a cruise ship, was looking for shuffleboard. I didn't find it, but I did find Harry, and we hopped in a car and off we went to the Ham.
Yep. And so we joked when we got in the car and said, well, we're about to ride a long time in a small confined space. You've been in Boston, I've been in New York. Whatever I've got, you'll probably get. Whatever you've got, I'll probably have. No going back. But obviously at that time it was a ha-ha joke. Fast forward to the next day, we're pulling into Alabama, and I noticed as we were pulling in, I said, gosh, I'm getting kind of chilly. So I had to put a fleece on. Didn't want to psych myself out, didn't want to, figured, oh, this is nothing. By the time we got to the driveway, though, what started just, I'm a little chilly, it turned into frank chills. And honestly, at that moment, I knew that I almost certainly had COVID, and that I just rode for 13 hours or 10 hours or whatever it is,
in a
very small
space.
car with my, to divulge his age, my mid-60s father. And so, I actually told him to go inside, get a thermometer and bring it out. And of course, the temperature is about 102. It was a Friday that we arrived. And so
Friday the 13th, by the way.
It was Friday the 13th, which should have been our sign. It was a bad day to drive. But we were not able, again, literally, and I'll let you speak to this, because it was a weekend and because it was so early. This was, March 9th, 10th, 11th, 12th, range. The ability to get a COVID test to confirm this was not exactly, a well-defined process. And so we weren't able to get COVID tested that Friday, Saturday, or Sunday. But honestly, we didn't really need it, because on Sunday, not surprisingly, 2 days later, Mike here popped a fever as well. And again, at that point, we knew, if anything, we could be good, true positive test studies for whatever, PCR test was being delivered at UAB. Fortunately, I'll quickly say my course was mild, relatively uneventful, a couple of days of fever, some fatigue, but ultimately kind of nothing more serious than that, a light cough. And then I'll turn it over to
So a couple things. So when we got there, we were supposed to turn right around and go to, those of you know, Dr. Ken Saag, who's a first cousin. He was having a birthday party that night, and his 90-year-old plus mom and dad were there. And we looked at each other and said, we ain't going. So we didn't. As we go into Monday, we both get tested. And both of us volunteer for a research study. And I think that's important to note. When I was doing AIDS work in the 80s, when there was a disease happening, we didn't have any treatments, there wasn't anything we could do about it. I learned early two lessons, three really. One was to participate in research. So we both volunteered and had blood drawn. At the same time, we're getting tested. The second thing is to go public with the story. So within a couple days, we were talking to different news outlets, from the Birmingham News to the Washington Post and other, even cable news, were, over the course, at least of my illness, were checking in from my isolation room upstairs, which I called Rikers Island. And and they sent the food under the door, so like only get pancakes or something, and I don't really like those anyway. And then finally, as Harry was getting well on that Tuesday, I was doing okay. I thought I was just had a mild case. I wasn't that sick. Didn't really have fever, a little bit of body aches. And then on that Wednesday, as he's recovered almost completely, at about 5 or 6 o'clock, it's like all hell broke loose for me. This is about day 5 or 6 of illness. And it was in essence a cytokine storm. So I could almost name the cytokines that were going around, IL-10 or interferon or IL-6. A cute little saying is clean up on IL-6, but you can do a lot with this, at least in jest. But the reality of it was horrible. So I'd have shaking chills, body aches, the top of my head hurt, brain fog, cough, shortness of breath, fever, inability to sleep, restlessness, and I've got a pulse ox that I'm watching drop to about 90 and sometimes 89 by about midnight. And then I played that game of putting it on different fingers to see if I could get a better reading. And I know you're supposed to go to the hospital at below 90, but I figured I had a doctor watching me and I didn't feel that bad. And it never went much below 88, but by the next morning, I was fine. By Thursday morning, felt back to normal and thought, okay, this is over and hallelujah. But then the next night, right about 5 or 6 p.m., like Groundhog Day, the same cytokine storm would happen. And this went on for me 8 nights in a row. Mornings, afternoons were fine. I even gave a Rotary talk to the downtown Rotary on the Wednesday that I was sick because I felt okay. And then that night, boom, just terrible. And then on the 9th day, it all just kind of went away. I was left with some residual shortness of breath, something akin to something called POTS, where there was tachycardia. And the other thing that I wanted to get to was that the third thing I learned from HIV patients was how to cope emotionally with a disease for which there is no known treatment that could be fatal. And I drew on those experiences, the stories from my patients in those days, and just said, you got to go a moment at a time and look around and see what's available in terms of treatment. So Harry, you were the treating physician during that time. What was your assessment of your patient?
Scared, 4-letter wordless, that begins with an S. But, it was a very, again, I would say there's a reason we say don't treat your own family members. It was very stressful, to say the least. As he alluded to, the scary thing about COVID, whether it was him at home or subsequently at NYU when I went back, is you don't know where the bottom is. COVID is a roller coaster ride you never want to be on. But once you know you have it, everyone's ride looks different. And some people have a really boring, you take a little kiddie ride around in a circle and that's it. And you kind of look and say, that's it. And those are the lucky ones. And for some people, you don't know where the bottom is. You think you're at the bottom, but actually it gets worse and worse and worse. And, the scariest part, both for my dad, during those times when the O2 sat was dropping at night and I was saying, we really should go to the hospital, and absolutely not. And calls to try and figure out how do I get a home how do I on the black market get a home oxygen tank without going through a DME supply, a traditional DME supplier, which we didn't do, by the way, but we were considering since he was a very stubborn patient. But also, again, therapeutically, what do we give really meant just calling the Rolodex of, again, this is mid-March. I mean, most places hadn't even seen many cases at all. I was on the phone with an intensivist down in New Orleans where they were seeing a lot of volume. A guy up in upstate New York that was seeing a good bit of volume. Obviously, some research colleagues across the country. And the honest truth is, and this was really the same experience back in New York and when I was back in the hospital, is we don't know. We ain't really got a clue. It's basically the Wild West. Sure, maybe, maybe this, maybe that. And ultimately, because my dad was, because he's obviously a doctor, he ultimately kind of made his own calls on the medication regimens. But the real key, or the thing that was probably the scariest part of COVID, and still is today for all the, again, sadly, it's still going on today, is you just don't know where the bottom is. But other than kind of, hoping, praying, and watchful waiting, there was not much else to do.
So I had a lot of friends who are virologists, as you can imagine. So I was on the phone with them. There really wasn't any known therapy. There was debate back and forth because it's something called an angiotensin converting enzyme 2, an ACE2 receptor. I was on a ACE blocker. Was it better for me to stay on that or go off of that? I stayed on it, but we didn't really know if it was making it worse. There was a French study that came out on March 22nd, which was about day 7 of my symptoms. This guy from France who said that hydroxychloroquine worked based on 22 patients. My cousin Ken is a rheumatologist. They use a boatload of hydroxychloroquine. He said it's safe. What's the harm in trying it? So I did. It didn't do much that I could tell. But I continued for about 3 days and said, nah, I don't really like this. It's upsetting my stomach. And so I just made it through on brute force and hope and luck that it didn't get worse. What I learned later that I'm glad I didn't know at the time was that some people whose oxygen levels dropped to about 88 or 89 within an hour can drop into the mid 70s like that. Fortunately, that didn't happen to me, but it happened in the ER a lot. And those folks go right to the ICU. So I got lucky and dodged the bullet and then recovered. So maybe we'll segue over to, maybe we can, hi Rucker, your bike's on.
With you and me about thing, but I was 15 minutes late, so I missed most of it. And
Good.
I'm watching the
And
Braves.
so what we might could do while we listen to Rucker tell us about his life.
I want to talk to you.
We can talk about what we did afterwards.
Sure.
And for the next months or maybe up to a year, because we need to go a little faster. But Harry, what'd you do when you left? I was better.
Yeah.
You left.
So fortunately, he recovered, and again, a new appreciation both for the desperation that patients and their families face when there is no good option, and the depths or the reach that they'll go to try and find anything to grasp to say, is there anything else we can do? And reaching into off-label medications. Unfortunately, once it got better, I said, well, New York is on fire right now, so I need to obviously get back. And obviously, I felt pretty confident, although we didn't know at the time, that compared to my colleagues, that I probably had a decent amount of immunity compared to them. And so the first day back was a really interesting day for 3 reasons. One, again, this was probably late March now, we'll say, I don't know, early April, something like that, still early on. And when you walked into a hospital, when we walked into the hospital that day, it wasn't required still that you wore a mask, not even a surgical mask. So even, in kind of late March, I walked in without a mask on, which again, and today, clearly if you go into a patient room, you weren't N95, but this was still the days of, we weren't even to the point, this was so early, it wasn't even necessarily obvious, except when you were directly in a patient room, that maybe we should be wearing masks at all times. The second thing that was fascinating is when I walked in to my team, as a hospitalist, I'm used to having a hospitalist NPs or PAs, mid-level, assistants or internal medicine residents. That's how we do it. Very similar to most hospitals or academic centers. My team was a PM&R resident and a plastic surgery attending. That's right, an attending who generally does ambulatory only plastic surgery. My team that day was, a gentleman at, good ways, more experienced or, wiser, I'll say, than myself, and a PM&R resident. And at that point, I was like, oh shit, this is not normal. So of course I asked the next logical question, which is, so are we on like a COVID floor here, or do we just have like the non-COVID patients? And they both looked at me with a very peculiar face and said, of course this is a COVID unit. Every unit is a COVID unit. this whole hospital is a COVID hospital, and every doctor is a COVID doctor. And so that's when it really hit me that NYU, which is a pretty big place, I'd say about 450 beds, literally every single bed was a COVID bed. There was no other unit, even the ORs were housing COVID patients, and every doctor was a COVID doctor. And obviously, as you can tell, they were trying to strategically staff to make sure that every team had at least one hospitalist or obviously intensivist or somebody who felt comfortable, who did this regularly, and then basically supplement it with whoever is available. A very scary time because everybody was obviously still very concerned about not only their own safety, the safety of their patients, but their own safety. And obviously, being on the floors, our job was to basically, take folks from the ER that didn't need to be intubated. We were doing high flow. Basically, if you needed high flow or less, you come to the floors. If you need to be intubated, you go to the unit. That was it. And while you're on high flow or nasal cannula or whatnot, it truly was, when I say the Wild West, this was the time when D-dimers were through the roof and we weren't sure, does that mean we should empirically anticoagulate? We weren't really sure about the steroid thing at the time. So, it was kind of dealer's choice whether to throw steroids at somebody, dealer's choice whether to throw tocilizumab. It truly was the Wild West of medicine. And beyond that, the second thing was the hospital, but for the staff, was empty. And there's never been an experience, obviously, before where we're flying so blind clinically, while at the same time, unfortunately, a lot of the conversations are, look, we're on high flow, the next step will be intubation, advanced care planning, or what would you want us to do if things got worse? And, for a lot of folks, the decision would be, if they get worse, let them go, or we do not intubate, do not resuscitate. And therefore, a lot of FaceTime and kind of, phone call based, last calls with family, which obviously, my closing on kind of the hospital side, and we can talk more about during the questions and answers, is, I really thought during my time in New York, which was, this kind of lasted all through April, May got a little better. By June, we were kind of out of it, or at least, pretty much out of it, almost back to normal, is surely this will be a New York City problem. Surely no other hospital, surely very few other physicians, nurses, respiratory therapists will have to experience the emotional, physical, psychological trauma of what that experience is like, and having no clue what actually to do other than, supportive care and throw whatever you want at the patient. Two, having to watch folks, as he said, just crash for no reason, get better, then crash again and be right back, et cetera. Three, obviously have to die without family. Surely this won't be something that every healthcare worker has to experience. And probably the saddest part to me is, having gone through it on the earlier stages, is now knowing that unfortunately every physician, every nurse, every respiratory therapist, every healthcare worker's had to feel the same pain point that I just described, is so unsettling. And I just, I think we don't talk about enough in the mainstream the toll that this is taking on all of us, on the healthcare workforce. And I just, it is so upsetting that the experience that I had, now anyone on this phone call could probably tell, a horror story too about their own experience, whether it was directly or indirectly. The true pain that it's caused beyond, obviously the patients, but to all of us as healthcare workers.
So while he's doing that, I've recovered. I picked up where I left off in terms of trying to be a spokesperson for the disease. I think my unique position of having been both a researcher, patient, infectious disease doc, was helpful. I tried to encourage the community to wear masks by that point, by mid to late April. And I think we did a good job of quasi-locking down, but our patients ran thin. And when we did a good job of doing that, ironically, the caseload didn't spike. And everyone said, what's all the fuss about? We're suffering here. Let it go. So Memorial Day happens and people start acting like, partying like it's 1999. And in comes July and this real big wave hits Alabama. And so I roll up my sleeves. From mid-April onward, I'm working in the COVID outpatient clinic and trying to keep people out of the hospital. And trying to keep a reasonable voice out there for what we should and shouldn't do. And I'll just fast forward and say that I've been continuing to do all of that over the course of, since that July especially, and into the winter months. It was awful. And then watching the spike hit July 4th, when we thought it was over and everybody went back to partying, and we've been devastated over the last couple of months. But here's what's going on right now, and this will be a good segue to Q&A. I've been involved in AIDS research since 1985, and that's over 35 years. We've looked for an AIDS vaccine, and we haven't really even been close. So this time last year, when they were talking about these the COVID vaccines, said, "Oh, good luck with that. It's not going to work." And then lo and behold, on the 1st of December, we get these, what I call miraculous, like a Christmas, Hanukkah miracle, that these things not only worked well, they were very safe. And wow, this is our Deus ex machina. This is the gods pulling us out of peril. And wow, this is fantastic. And never in my wildest dream did I think there would be resistance to taking the vaccine. If you think back, January, while we're getting clobbered, people are driving all over the Southeast trying to find a place where they can get their shot. I said, okay, that'll continue till the supply picks up in March or April, and then we'll have enough supply and we'll be out of this by the summer. Because who would not want to have a vaccine? This is fantastic. We only had one, we had three. And what's going on now, and just within our community and throughout the Southeast especially, there's so much resistance to a vaccine. I cannot explain it. I've tried to understand it. But to me, it boils down to this. The evidence is overwhelming that vaccines work. How do we know? Not just from the studies, but just this last surge, almost all the deaths are people who were not vaccinated. You look in the paper and there's a minister here or a commentator on the radio there or a policeman or you name it, their story is highlighted and none of them have been vaccinated. You go into the hospital and 98% of people who died were not vaccinated. 93% of people in the ICU, not vaccinated. And we're saying that from the rooftops, screaming it, and it's not registering. There's a resistance to this message. And now what we're dealing with is the question of mandates. I'll take that word and throw it away. It's too emotional. Why don't we just call it a requirement? That people should be required to get this vaccine. You say, why? My opinion? Because, yeah, you have a choice about what you might do for yourself. I agree with that. But that choice has boundaries. When it starts to bleed into other people's choice or other people's lives, that's where your choice becomes no longer that optional anymore. And that's what we're dealing with here. People who are immunocompromised, who've been fully vaccinated, even with the booster. I saw two of those folks today, a heart transplant patient and another one who's on immunosuppressive. We gave them monoclonal antibody, but they had 3 shots and they still got sick. So that while they're out in the environment, the person next to them who's not vaccinated, who just came down shedding a lot of virus, is affecting them. So to me, it's no different than laws about you aren't supposed to text and drive. Yeah, you'll be in an accident, but you could take somebody else out with you. Or drinking and driving, same story. There are certain things we do as a society, not only to protect ourselves and our families, but to protect our community. So if you sense energy in my voice, where it's coming from is from all the healthcare workers that I'm working with for the last 3 to 5 months, who are taking care of the patients in the hospital, the vast majority of whom are unvaccinated. And we're saying to ourselves, these deaths are preventable. And we've all taken an oath to help people, but there's only so much we can do. And just watching this carnage happen and knowing that it's totally preventable is enormously frustrating to me. And I think most of my coworkers. So I'll stop there and see what kind of questions we have. So Beth, I'll turn it over to you to MC this.
Okay. No pressure, right? Okay, so first, did either of you experience like long-term side effects from having COVID?
Yeah. Harry, did you have anything?
The only thing I would say is there was a decreased exercise tolerance for at least 30 to 45 days.
Yep.
And obviously, clearly, I wasn't like I was exercising that much on I'll say the 15 days I was in Alabama dealing with, his illness and whatever, but I'd felt fine for, we'll say 10 days before I got back to New York. And I went on my usual little jogging route, and I probably made it, 100 yards, and I was already a little bit winded. I said, oh my God, this is not normal. I mean, I'm not saying I was expecting to go my usual distance, but this was way out of proportion. And it took me a long time to work back. Now, again, today, whatever it's been, a year and a half, no long term, but I would say there was a 30 to 50 day exercise tolerance difference that really took a long time to shake. Other than that, though, that was it for me.
Yeah, I had some hearing loss that didn't come back. And that's not talked about very much, but it obviously happened. And I had exercise tolerance. Mostly, there's something called POTS, postural orthostasis tachycardia syndrome, where just standing up, the heart rate will shoot up. It's a very common long COVID symptom. I had it for maybe a couple weeks, and then it fortunately went away. But I'm seeing some patients who have had that pretty bad. They just walk to their mailbox and their heart rate goes to 150, or they're in the shower and they got to sit down because they get dizzy because their heart rate took off. So long COVID is real. It's estimated to happen to about 8% or so of people who have had symptomatic COVID.
So this next one, we had a couple that had submitted it prior to, and then we've also had it mentioned in the chat. If you guys have noticed any clinical or immunologically characteristics that kind of predispose people to having worse cases. The person that asked the question in the chat also included population, so minorities having more of an effect on minorities, people that are obese, a greater risk, people that are substance abusers. Have you guys noticed any of that playing a part?
Maybe I'll start, Harry. You can focus on disparities a little bit. The medical side is obesity, age, first off. Anybody over the age really of 50, but especially 65, higher risk of death. Obesity, diabetes type 2, hypertension, interestingly. Those are the sort of the primary. Then, of course, underlying lung disease or heart disease. Anybody who's immunocompromised for whatever reason. And usually it's from immunologics, immune-based modulators, transplant patients, chemotherapy patients. So they're at much higher risk of a bad outcome if they get COVID. Harry?
Yeah, I mean, I think I'm not familiar with any data on kind of a biological reason why there would be a difference on kind of race being predisposing. I think what we are seeing, though, is that COVID disproportionately hit communities of color, lower socioeconomic areas. That's both in New York, we saw it. We've seen it in other areas, certainly Louisiana, and likely Alabama, though I'm not familiar with the data specifically. And that's likely multifactorial. There's not a one reason why. Part of it, again, and we know in New York, I can speak a little more to, is again, there's more folks who are cohabitating in smaller spaces. It gets back to why New York City and some of the outer boroughs outside of New York were just unfortunately affecting folks at the lower socioeconomic ladder. Secondly, though, was the access to reliable information. And one thing that I would say really kind of ties everything around the sociology around vaccine acceptance or hesitancy is healthcare moves at the speed of trust. And ultimately, folks listen to and look at trusted sources. And for all of that, regardless of where you live, regardless of your socioeconomic status, we all choose where our trusted sources come from. And ultimately, I think that we we, again, in New York, and again, I'm sure, again, I can only really speak for New York, is it was a longer and slower process to find the right key allies in communities, particularly the underserved communities, to get the right messenger, to get the right information, to dispel myths, or to work on, have those one-on-one conversations. And ultimately, those conversations were best driven by local members of the community who really who had that trust. And so there's no question that for again, a multifactorial number of reasons, COVID, I think, disproportionately impacted those populations. But ultimately, it takes those one-on-one conversations. Unfortunately, there's no mass production scalable solution to addressing to addressing behavior change.
So the disease of COVID is characterized by a cytokine storm that takes people out ultimately, well after the virus has been managed by the host. It's like it messes with the off switch or the stand down command to the immune system. It just keeps revving despite the fact that the virus is gone. And that's kind of what kills people. But there's another thing, at least in the United States, where somehow or another, the virus has infiltrated the politics, and that is destroying the trusted voices that we normally listen to. And I've worked, for example, with Tony Fauci for over 30 years. I know the guy really well. He is about as apolitical as you can get. Trust me, I know. I've been around him. The last thing on earth is he's thinking about politics, and yet he's been labeled as being leftist, which is crazy. I mean, the guy is historically has been a Republican and conservative as long as I've known him. And to listen to that, I kind of go, where is that coming from? It just never, somehow or another, that's killing more people right now than anything else that we're dealing with. And we've got to get that fixed. So somehow or another, that extra disease, that extra part of the disease is really the legacy of this virus that we still are fighting through at the moment.
So this next question kind of revolves around the vaccine conversation. It says, can you address the immunity from having COVID versus immunity from the vaccine? And to kind of tag on to that, someone else asked, have we ever seen people getting breakthrough infections with other vaccines like we have with the COVID vaccine? And shouldn't cells kind of be kicking in at this point to remember that COVID is what it is?
Okay. Yeah, so the immunity from natural infection is real, and it's there, and it's fairly robust for a while, and it wanes. So we see breakthrough infections in people that have had COVID. So I saw a woman today, it's not like we planned this, but who did not get vaccinated. She had COVID back in April, and here she is again with COVID, and she's requiring monoclonal antibody. I asked her why she didn't get vaccinated, and she said, well, I didn't think I needed it. Well, the best immunity you can have is like what I did. I had COVID, and then I got vaccinated. And I've measured, because I'm doing these research studies, the amount of neutralizing antibody, not just antibody, but antibody and a lab test that takes the virus out, neutralizes it. And my levels going into December pre-vaccine were reasonable. My levels coming out after the vaccine were astronomical. And so much so after one dose that I elected just to kind of wait. And I didn't get my second dose until August, and waiting for the results from the last thing. But I can just tell you, they're probably through the roof, and they're broad. My immunity, not only against SARS-CoV-2, but against every variant of SARS-CoV-2. And for whatever reason, because symmetry or similarities, I had antibodies that neutralized SARS-CoV-1, the original SARS virus. So that's the best immunity that you can get. And we know that I've already given you the hospitalization and the death data. The vaccine really works, even in immunocompromised people. It's a necessity if we're going to bring the virus under control for the individual, also for the community. And oh, by the way, if we get 95+% of people vaccinated, we reduce the likelihood of variants emerging, because variants are simply a function of a virus that's replicating unchecked. And that happens when people have a naive immune system to the virus, and it just revs up at about 1 to 10 billion viruses a day. makes a lot of mistake when it replicates, and by chance, a variant emerges. As far as how, I think the other part of the question was the natural immunity, there was also the vaccine, and there was one other, breakthroughs. Yeah, almost every vaccine will have a breakthrough infection. I mean, measles, not so much. We don't see that. But flu, 50% of the time after a vaccination, there's breakthrough. But just like with COVID, the immunity is sufficient in most every case to keep people out of the hospital and to prevent death. That's why we need a flu vaccine.
The only thing I would add for, not all of us, again, I can be the non-infectious disease doctor, is kind of the generalist hospitalist that, probably doesn't want to necessarily, to take away the headline for me from all the data, because probably one of the most common questions is, hey, Harry, I've had COVID. Do I still need the vaccine? I think that, to me, it's, there's just basically three tiers. I think it's relatively unequivocal that in natural infection plus at least one dose of the vaccine is the strongest. And it's unequivocal that no vaccine and no infection is the absolute worst. And then there's this middle tier of natural immunity versus 2 doses of a vaccine. And I think this is, something that, reasonable people, again, can. I've had folks email me all the time, articles saying one's better than the other. But the point is that, there's definitely power to natural immunity. It does look like memory cells do persist, but they're not perfect. Nothing is perfect. And again, no matter which of those tiers you fall into, there's always a risk of a breakthrough infection. But, if you're in groups, there's those top 2 groups, there's the risk of a severe infection is dramatically less.
Continuing on that vaccine conversation, what are your thoughts on the Pfizer booster for healthcare workers, given the CDC's departure from the ACIP?
Well, the ACIP is advisory to the director of CDC, and she overruled their advice on one issue, and that's about healthcare providers. And there was, if you listen to the transcript if you read the transcript, listen to the discussion, there wasn't uniform consensus on the ACIP. But without getting too much in the weeds, here's the bigger picture. The immunity from any of the vaccines appears to wane over time. There was an article in Lancet this past week. I wrote an editorial for it that showed that the Pfizer vaccine, as far as breakthrough infections, was 85 or 87% protective in the first 2 to 3 months, that dropped to 47% after 6 months or longer, and it was any variant, so it wasn't just Delta. And that makes sense to me, because to me, the way I think about it, the antibodies are really the most important for preventing symptomatic infection or breakthrough. But as Harry just mentioned, the other arms of the immune system, the T cells, the cytotoxic T cells, are still quite active. So in that same study, even though there were breakthroughs over time, hospitalization and death were still prevented to a large degree, to the same degree, from month 1 to month 6. And at the end of the day, that's what you want. Final point is, everyone criticized or tried to criticize this was done too fast. No, it wasn't. It was done extremely well in a very efficient way. So it's not that the original primary data that got the drug approved was flawed. What we're missing, because we went quickly, is by definition long-term follow-up. Most vaccines, before they're released, have a couple of years of durability data to know if and when a booster, what dose of the booster, all that. By the time the vaccine's released, that information is known. Those are the data that we're looking at now. And so when I pull back, this virus is going to be with us for at least a decade, probably longer, maybe for a long, long time. And we're going to need to get boosters every so often. My best guess, and underscore the word guess, is that it'll be annually. Once that 3rd shot is given, whether it's given at 6 months or 8 months after, maybe even a year, I don't think matters. But what does matter is that this virus is going to be around. It's going to continue to be a threat. And no matter what we have in terms of therapeutics, and they're better now with monoclonal antibody, this molnupiravir, which is the Merck drug that will likely get approved in the next 3 weeks, like Tamiflu for COVID. That's treatment. The prevention, as Benjamin Franklin told us a long time ago, is much, much more efficient than the cure or the treatment. So we need to get everybody vaccinated right now. So those of you who have friends, or if you yourself are hesitant, go for it. It is safe, and it will protect you and your family and the community.
I think you saw my question sheet because one of them was, would COVID continue like influenza? So that kind of covered that. Someone else asked if you felt like we are now in an endemic and no longer a pandemic.
I think
yeah, go ahead, Harry. You take it.
I think it's a little bit geographic, and I think it's a little bit, we have a very big country, and I think transmission rates are different, vaccination rates are different. So I think some areas perhaps we're moving towards endemic, perhaps some areas are still in pandemic. But as Mike alluded to, it's to me, again, it is inevitable. It will be, and again, in certain places is already endemic. I mean, ultimately, the amount of hosts that are completely naive to the COVID-19 virus will continue to decrease over time, whether that's through natural infection or immunity, and it's going to be harder for the virus to replicate and spread at the same speed and agility that it has for the past year and a half. Having said that, what we don't know is that I do think, like I said, it'll enter this endemic phase at some point. But really, the thing about this, and even I think for all of us, I don't think anybody could have really predicted Delta. Meaning, I don't think anybody could have predicted how quickly such an efficient virus mutant could have spawned. And so it's certainly possible, at least, it's impossible to really know. But I do think we're in a transition phase. But that's a big think there, and a lot of hope, and a lot of hopeful thinking. So I'll turn it to Mike.
Yeah, two quick points. The terms endemic, epidemic, pandemic are by definition geographic. So endemic means a local area, just sort of self-contained. Epidemic means in a general country sort of thing. Pandemic is global. So we are transitioning from epidemic in the US to more endemic, depending on all those factors we just talked about. How we move forward is really up to us, and we got to get lucky that another variant doesn't emerge, because everything Harry said is right, assuming that no new variant doesn't emerge that can evade the immunity from either natural infection or vaccination, and then we can have an explosive epidemic again. So the best way we can control that is to get vaccinated. I know I sound like a broken record, but it's public health 101.
So this is kind of timely with holidays coming up. For those that are vaccinated, can we gather for the holidays with unvaccinated family or friends, and what should we keep in mind for those gatherings?
Harry, you take that.
So to me, these are the very real world practical questions that hit my inbox or my text messages every day from friends and family, whether it's about the holidays, whether it's about my child at daycare was exposed or tested positive, or a coworker or colleague. These are the real world practical questions that I think, you can't go and pull a New England Journal of Medicine randomized control trial on, meaning there's a little bit more art here than science. And so ultimately for all of these questions, it comes down to risk benefit equation. And, all any of us can do, meaning at the advisory level as a physician, whether it's a curbside kind of consult or somebody asking for just, personal advice, or being in the clinic room and having to, counsel folks, just like we counsel folks on the risk and the benefit of, a blood thinner or a surgical intervention. There are, no one can really define the benefit of what it means to be able to spend that time together or to be with folks in person or whatnot. And ultimately all we can do is advise of, what are the safest ways to do it and what adds risk. And the nice thing is there are a lot of ways that we can mitigate risk. And obviously, ultimately though, each of those decisions for things like that is not necessarily a blanket answer. I think it's difficult. I think what you're looking for, unfortunately, is a nuanced. I mean, you're looking for a kind of a broad strokes. It's okay or it's not okay, and unfortunately, that's a question that's going to have more gradient to it and more gray. But generally speaking, I would say, boy, you can mitigate a whole lot of risk if you can help. If you can convert those folks unvaccinated, and you are taking significant more risk by as compared to being around only vaccinated folks. But ultimately, it's all just a scale of trying to weigh that benefit and mitigate risk.
I think we're coming out of the worst of the Delta phase that we've been in, such that by Thanksgiving, I think the community rates will be down to 2 to 5 per 100,000, which is very low. So I think vaccinated people can pretty safely get together. Unvaccinated people sprinkled in is a bit of a wild card.
Do either of you, I'll ask this one and then there'll be one final question. I think we'll probably have time for these last two. Do either of you have interest in the origin of this disease, or is that a waste of time to pursue because it's tainted by politics, or is it just kind of unsolvable?
Scientifically, I think we're all very interested in it, and I'd like to strip the politics away. The two possibilities leading are that it's a natural infection that emerged from a zoonotic source, probably bats, but maybe another source. And then the other possibility is that it was a laboratory accident that occurred out of the Wuhan lab. I don't think there's any possibility within reason that the Chinese government deliberately unleashed this, but there were studies going on in the Wuhan lab. They were doing it in BSL-3 level containment, which if the rules are followed, that makes it very unlikely. But if there was a breach, it could have gotten out. Based on what I've read and what I've looked at in terms of sequencing of the virus, it seems more likely that it emerged in the bat community. But the only way we're going to know is to get the lab notebooks of the researchers at Wuhan and see exactly what constructs they were working with and see if there's anything there that resembles SARS-CoV-2. Until we do that, we're wasting our time and effort wringing our hands or talking about it, because that's the only evidence besides what we already know about the sequence and what we've seen in bat communities. But I will say that it's highly plausible that this came out of the bat community.
Yeah, and again, as the non-researcher or more of the just the clinical side and not grant-funded researcher, meaning we come from different. He and I come from different experiences. I have kind of a two-way answer. The first is no, in the sense that whether it came from the lab or from bats, it doesn't really matter for how we have to deal with things today. So it doesn't really matter. Doesn't affect any of really the things we've said today. I do think that it is important to continue to understand the how and as much as possible understand whether it may have come from the lab, but more importantly, I do think we do know that there's lots of interest, I'll say, around gain of function research, and I think that there is a genuinely healthy conversation and debate around what is the risk and benefit around gain of function research in general, both the United States and abroad. Having said that, I don't think it's productive to get into spend a lot of energy on the actual, specifically for COVID, was it the lab or was it the bats? And certainly, I think relying on the Chinese government to help inform that, which will likely take, may be we may be waiting a long time. So those are my thoughts.
So this last one, what recommendations do you have to help the public be judicious consumers of COVID information? And then to tack on, do you have any suggestions for talking points with those who have vaccine hesitancy?
Harry, I'll let you get the last word. I'll start and just say that find your trusted voices. I had a call today with folks from the power company. And as I was explaining everything I've more or less talked about just now, I said to them, if you were coming out to my house because there was a power issue, and you came to my door and explained it to me, I would trust you because that's where your expertise is. I expect you to keep me safe. I think you're going to keep me safe from power surges that can catch my house on fire, and you're going to keep me safe from getting electrocuted if I walk outside. That's your job. Well, my job as a public health person is to do the same, except in the realm of transmissible diseases and other things regarding public health, like not texting and driving and that type of thing. What I don't understand is why we ended up assassinating the trusted voice in our country, who we should be relying on to give us answers. So the trusted voices are the traditional trusted voices, the public health officials. There's no political agenda here that I can see from public health people, except to put this disease under containment and try to get it behind us. That's the only mission: save lives, stop the transmission. Full stop. Nothing more to it. And if people don't believe that, I can't change that. But ignore completely whatever it is you might read on Facebook or other social media. It's almost guaranteed to be wrong. So put that aside and don't pay any attention to that. Focus on the people whose job it is to keep us safe.
So I would say that this experience in counseling folks that are vaccine hesitant has been very eye-opening. And my practical advice of what I do, and I found this to be reasonably effective. It's not 100%, but it at least has been more effective than most. Is the key is this concept of as listen to understand. And what that means is, when somebody says I'm not wanting the vaccine, the two go-to phrases is, tell me more about that. So you've got, before you start peppering them and hitting them with the stats and hey, let me tell you all the good things it can do, start with, tell me more about that, or help me understand. And if those are the two phrases you can walk away with before you go into your, when I say medical jargon and this percent and that percent, that's going to help you live, you've got to understand the why, and you've got to dig. And that'll be very enlightening for that patient-doctor relationship. If you just say, tell me more about that, or help me understand why you think that way, you'll learn very quickly why, whether it's, again, as Mike said, what trusted source did they get their information? Well, my friend on Facebook put this, or my family member did this, et cetera. And now you can be more targeted and more thoughtful. What I wouldn't do is, jump right into the solution. I would really ask about 5 questions. Tell me more about that. And honestly, say it again. Oh, really interesting. And then how did that, try and understand your customer, if you want to think about it that way, and your patient. Understand what makes them tick. Understand why they think the way they do. And then obviously, once you feel like you understand for that unique patient what it is that's holding them back, address each of those issues kind of one-on-one. And ultimately, you do your best, understanding that, there are going to be folks that make the decision not to, but that's the strategy. So tell me more about that and help me understand, or my go-to lines to really address vaccine hesitancy.
Okay, well, this has been super enlightening, and I could probably keep asking questions. I know everyone else could. I want to thank everybody for attending, and thank you, Dr. Mike and Dr. Harry, for joining us tonight and kind of sharing your story and answering all of these questions. We've really enjoyed it. I know there were a lot of questions that we didn't get to, but I'm going to follow up with both Dr. Sags so that we can kind of get some answers to those questions that we weren't able to have time for. And we appreciate everyone coming, and I hope everybody has a great night.
Thank you, guys.
Thank you.
Bye.
All right. Thank you. Good night.
Thank you.